the scores of the grants that have been reviewed. We do not know the funding line. And we can't actually put a protocol in place that we can't afford. That would be irresponsible. So our job is to gather the input, to get it prioritized and organized. Once we understand the funding across the entire consortium, then we'll make the hard decisions about what actually fits and what cannot. Go ahead and flip forward. Thank you. So what do we do in the gap between CureGN1 funding period and the CureGN2 protocol, right? Go ahead and flip. And that is continuing to follow the CureGN1 protocol, right? So you're just going to keep going in CureGN1, keep your IRB open, follow the CureGN1 protocol. So expect no changes until you essentially receive the CureGN2 protocol and directions for what to do next, so that you just kind of keep moving forward. Same visit structure, same specimen collection, same case report forms. Go ahead and flip forward. So this is your chance right now. I'm really hoping to learn a lot from you. You have your big ideas. You have thoughts about what you'd like. So would you please actually, in order to be nice to our folks on the phone, would you come to the mic and let me know how you filled in the gap in that question. In CureGN2, I would like to propose. It's always fun, right? But you have to stand up. I'm so sorry. I don't know any jokes. This is going to be a long pause if nobody. I know that you've been sitting at home seeing your CureGN2 or CureGN patients and saying, "Man, I wish," right? "Man, I wish." Tell me what that would be. I can call names. Teresa, help me out. Thank you.
Refer to some of the things that we've been talking about on a different committee. So what I had personally asked for would be there a way to do sort of a chart review follow-up on patients that you can't get them to call you back and you weren't able to see them when they came in for a clinic visit just because you couldn't, because they don't usually come in according to my schedule. They come in, at the doctor's schedule. So if we could just do, it could be as limited as a, relapse and survival follow-up. If they had labs, there isn't really a mechanism now to capture the data if you didn't either see them or talk to them.
Great.
So having a chart review sort of status for a follow-up. So
perfect. Thank you. Good suggestion. Thank you very much.
I have a question. And
okay,
just
please.
To go back a little bit,
Yes.
because it was your last slide. Between June and sort of good news comes in September, hopefully, and then IRB, what are we supposed to do with our current patients over the whole summer?
Yeah, so the study stays open. The study is open now, and it will stay open. And so you'll see them. You'll see the patients on schedule.
So continue
keep doing
our same visits under the current protocol, but new patients not till next year, new protocol not till next year.
Correct.
Okay.
That's exactly right.
I don't want to lose them.
No, don't lose them. Very important. Other suggestions? Oh, come on. All right. So, yes, please. I was actually just going to call your name, so thank you so much for standing up. Good.
Maybe based on the pediatric ages, but just one different kit. No, that way, what else did we talk about in the whole form?
I'm so sorry. Yes, you have to.
She's not as loud as I am.
Well, and it won't catch on the mic, so thank you so much for getting up. I beg your pardon. But, we all sit too much anyway, so this is fantastic. Thank you.
So I think regarding the unique kit, it was the discussion was about using only one kit for all visits, but also reducing the number of tubes in the unique kits. And I think this change was accepted by the biosample committee. So they removed some of the samples, like sodium heparin and a few more. And the discussion was also about adding vials for the 24-hour urine, because now we are asking patients to bring the 24-hour urine, but then we collect only either 3 or 5 depending on the visits, which doesn't make much sense considering the amount of urine they are bringing and the effort they are doing. So also it looks like for ancillary studies, these samples are valuable, so the idea is also to increase these samples. Another change was the discussion about receiving samples from outside. So whenever a patient is not able to come to the site, they can collect the blood sample remotely and send the samples to the CureGen site. Of course, this is not possible for all samples, but then the biosample committee, I think they agreed. This is not
Hold that
confirmed
thought.
yet.
Yeah. Hold that thought.
So
Yeah.
there are some changes that
sure,
will
right.
help with retention.
Right.
And then I think these are the main change. I think also some flexibility about the visits is under discussion.
Gotcha. So again, I'm going to sort of turn those around because we're looking at these as suggestions because there's nothing for CureGen 2 that's been decided. So we've heard things like the case report forms are too long. When you print them, it makes the visits be kind of cumbersome and difficult. You feel like you're flipping pages as opposed to sort of having that efficiency. The kits actually are difficult because you have to pick different flavors of kits for different visits, and that makes it difficult because the kits may expire or you might grab the wrong kit, and that makes it difficult. But knowing the prioritization and the tubes by patient size is important, so making sure that we've got the directions just right to make it easy in a universal kit. I think I'm hearing that. I hear you say this question about, is it possible to try to take advantage of blood work or specimens that might be collected off-site to be able to bring into or ship into CureGen. And again, at present time, we're separating CureGen 1 from 2. CureGen 1, no. CureGen 2, we have a biospecimens committee that's thinking very critically about what specimens that might modify for CureGen 2, what we want, when we want it, how much we want, but also what type of specimens and what might be actually scientifically valid still if they're captured with a delayed processing activity. And so those are conversations that we are actually having exchanges with each. That's one of the particular committee's job, is to consider all those options and to bring in some opportunities because of these questions that have come in. Keep going. You're doing great. Any others?
Yes, I mean, there are some small changes. I'm not sure it is worth to talk about them, but one main change suggested for the link was to implement some flag systems and system to flag patients who didn't consent to DNA, for instance, to help the coordinators to know which patients consented for DNA and which patient did not, which should help them in addition of internal work files. I mean, this is a main issue, and collecting those samples when patient didn't consent to that is quite worrisome. So this is an important change for the link. And then there are a few changes that have been discussed.
Okay. So thank you so much. That's great.
Yeah.
Other suggestions? Thanks.
Hi. So in the protocol for CureGen 1, we really have to stick to we try very hard to stick to a inpatient visit on visit 1, or their first block, a third of the year. And then the 2 follow-ups by phone call. However, a good amount of patients do not fall into their clinic visit that first, so we do have a kind of a safety net that we would be able to see them other times in person, as long as it's once a year. However, that doesn't fit into the original protocol. So to have that leeway in CureGen 2 would be an advantage, so we don't have as many outside of those specific window visits.
Okay, great. So some flexibility in visit schedule, so that in the inpatient versus remote.
Yes.
Okay, gotcha. Good. Thank you. Excellent. Other suggestions? How about suggestions that your patients might have said, I wish, or importantly, I would keep coming except for, right? So are there things that you think you've heard from patients that they've either asked for information or they had a suggestion that you would like to bring forward on behalf of your patients? Don't you want to have? I've had a patient that said, hey, I keep all of my data at home about my disease. I keep it on a spreadsheet. Don't you want more data? I have it, right? Which is fantastic, really, to think about how we can capitalize on more patient-reported information. Go ahead.
I know this is probably a budgetary issue, but I think the current website is kind of sad.
Me too.
I think if we could make it a little more patient-friendly, subject-friendly, and interactive, include a lot more information about the ancillary studies and publications, because I do think that our
research participants are really hungry for that information, I think a website is a really good way to do it. And I think there's a lot of work that we could do on the one we have now.
Actually a fantastic, thank you. So many great suggestions. And I'm just going to throw this back out for any of you in the room that really likes to do that kind of web-facing communication, thinking about the content or the design or things like that. I think this is a really great work group opportunity. So if this is something that appeals to you, if you have an interest, would you please let us know? That would be fantastic. Because, some people are tuned in to that kind of communication venue, and some don't see it, right? It's just the way it is, and so we want to capitalize on strengths within the room. Anything else? No? Really? Don't be shy. Okay. See, I just get to sit here patiently. This is my life. My life is asking people questions and waiting for answers. It's fantastic.
My patient calls me, I'm the vampire, because I always take a lot of blood from them. So they're asking to make the amount of blood less than the 11 tubes that we usually do in normal visit. And it's been going so far so good. I always talk about priorities, which tubes should be collected, and I let them choose how many tubes. But the minimum I can go is 2. So this is one thing my patient is asking for. The other thing is I have a problem with the time during, especially if I collect the samples. And if the patient, for example, he will say, okay, I will do it, maybe I'll do it after 3 weeks, 4 weeks, he will give me like deadlines. Some of them they don't. And after like 1 month, 3 months, or 2 months, I found out that, oh, this patient brought his or her urine, but I don't have the tubes, I don't have the stickers, I don't have labels. So that's one thing. I think the time during has to be like the labels, I can pull it out from the system and I can print it. That would be easier for collecting time during. Also, my patient asking about sharing progress, as you mentioned, from CureGen. I distribute the CureGen newsletter to them. One of the things that doctors asking me when I give them the clinician forms, especially if the patient is just diagnosed with the disease, so they have the first interview with them, and then the doctor give them the treatment, but there was no, like they did not evaluate the response of the treatment. So in that sheet, if you look at the answers, there is no answer for a patient who was treated, but there is no response to the treatment.
Sure. Unknown, right? It's the unknown response.
So I always get in dilemma with the doctor, like, what should I choose?
Okay, all right, good.
So that's one thing. So that's the thing that
Perfect. Thank you so much. And I know that later on today we'll talk a little bit about biospecimens and the types and the priorities and how to approach that. So I'm going to leave that to Krista and the other members of the team. But thanks for the input also to think critically, and I'll reassure you that folks are really thinking critically about what specimens, how much, for what purpose, what type. And so that's definitely part of our deliberation. Folks, thank you very much for your time. And you're going to think about this and go, oh, I should have mentioned. Just write it down, send it in, shout out at the folks in the back of the room. Anything that you can do to sort of help to be certain this is your chance. In the midst of these protocols, you'll recognize that CureGN1 had no protocol amendments in it. It had none. And the reason it had none was because it's easier to actually train and maintain a durable protocol. The second is it's incredibly expensive to amend a protocol. It's very expensive across 68, 70 sites in 4 countries. It's expensive. And this kind of funding, when we like all of our resources to actually go to help the study to be successful, as opposed to sort of changing at a whim. So this is your big chance to actually tell us what's working and what you'd like to see change. This is it. Okay, I'm not going to promise you that we're not going to amend a protocol for another 5 years, but this is your chance to make it as good as we can possibly make it, so please don't be shy. Thanks for your attention.
Testing. Check, check, 1, 2, 3, check, check, 1, 2, 3, check, check, check. Testing. Check, check, 1, 2, 3, check, check, 1, 2, 3, check, check, check.
cancel the session?
Yeah.
Okay. Hi, can you hear me? Yes. Okay, we're going to talk about the retention strategies. Here we have Sam Sharpe from the... Hi, can you hear me? Oh, yes. Okay, we're going to talk about the retention strategies. Here we have Sam Sharpe.
What's going on?
From the... Hi, can you hear me? Oh, yes.
It's echoing
Okay,
back
we're
like
going
the...
to talk about the retention strategies. Here we have Sam Sharpe.
What's going on?
From the... Hi, can you hear me?
It's echoing.
Okay, here we have Sam Sharpe from the Midwest Pediatric Nephrology Consortium, Maggie D'Angelo from UNC, and myself, Maddalena Marasa from Columbia PCC.
Okay, we're just going to cover today the basics of retention, why it's important to the type of study we're doing, where we are currently, and ways for coordinators to enhance retention and to overcome some barriers. So, what do we mean by retention? Retention in this study includes completion of follow-up visits and procedures as specified in the study protocol. Retention overall may vary depending on study and usually reflects the primary endpoints of the study. Retention should start in the beginning when you establish relationships with participants in order to optimize retention. Okay. CureGN is a longitudinal study. Without retention, we can't achieve study goals. So longitudinal studies, and Deb Gibson kind of just covered this, can help evaluate changes in patients over time and examine long-term outcomes. You can look at risk factors and the disease. So why did this disease happen to this person? And it can assist with establishing a sequence of events, patient outcomes in relation to treatment, exposure, and other variables. So inadequate patient retention during the conduction of a clinical study affects conclusive results. So during the design of a clinical study, calculations are made about how many people need to join in order to get the data we need. So if you think about what we ask at each visit, I know patients complain that the questions are redundant, but it serves a purpose. Over time, we're looking at, asking those same questions, looking at lab values and medication changes so that researchers can see how things have progressed, kind of achieve those goals that Deb talked about. And one of the aims of CureGN is to engage patients as partners in research. And engaging them serves two purposes. We meet that goal, but engaging them makes them want to stay in the study, therefore increasing retention. So Dr. Smoyer went over this. We are using this data when patients ask, what are you doing? It feels like nothing's happening. And one of the ways to increase retention is to explain to them, actually, this is happening. So so far, I think he said there were more ancillary studies. This is from the face-to-face this year. So there are numerous studies that are being funded, data that has been collected is being shared in the medical community at the ASN, peer-reviewed journals, things like that. So I'm sure that you all know this, but the current retention goals are at least greater than 85% of patients have to have at least one in-person visit per year and 2 additional remote visits. When patients miss 3 consecutive visits, they're considered lost to follow-up, and this is detrimental to our study. And so that's what we're going to kind of cover, ways to avoid loss to follow-up if possible. Currently, we're having, low compliance rates with the CureGN protocol, and hopefully in CureGN 2.0, we can increase that retention. And again, high-risk sites are being identified and closed.
So I'm going to give you an overview about the current retention rate of the CureGen study. This graph shows the visit completion over time. The columns in the back, each set of columns represents a visit. So we have, it used to work, now it doesn't. Anyway, so we have 3 columns for V0, then 3 columns for V1 and so forth up to year 4 V2. The columns on the back are the expected visits. The columns in the center are the completed or occurred visits, and the columns on the first line are the visits that have been missed. Of course, the expected visits are decreasing over time just because only a minority of patients reached the 4th year of the study. And of course, also the completed visits are decreasing. But the issue is that the completed visits are decreasing proportionally more than the expected visits. And this is shown from the percentage of the visit compliance at each visit, which goes from 98% at V0, 87% in V1, year 1, 83%, and then down to 54% for year 4 for V2. The current year 4 V2 completion rate is actually higher. These data were from December. But even if they are higher, the bottom line is that the CureGen overall visit compliance is decreasing over time. Now we are going to look into more details. Columns represents patients who have been terminated and whose termination form has been completed in the link by the study coordinators. So this is in addition to the patients who missed visits without being withdrawn. There are several reasons why patients are being withdrawn. It can be a participant choice, investigator discretion, patients who moved, patients who transfer care, lost to follow-up, ineligible patients, and also, unfortunately, patients who die during the study. The top choices in determination form are the participant choice, so patients who don't want to participate anymore, but also patients who are lost to follow-up. So half of the patients who have been terminated are actually lost to follow-up. There are many reasons why patients are lost to follow-up. Some of these patients just move or they transfer care, but they just don't tell that to the coordinators. And there are also patients who reach end-stage renal disease, so either transplant or dialysis. And these patients may not want to participate in the study any longer, may not be even aware that they have to participate in the study even after they reach end-stage renal disease. Or maybe they just transfer care and it is not convenient for them to be followed up. However, per protocol, even for enrolled patients who progress to end-stage renal disease, additional data collection still have to happen. They need to do at least one in-person visit after the end-stage renal disease event. And then for participants in dialysis, they should be followed up via phone visits every 4 months until they receive a transplant or they are deceased, or until the end of the study. So basically for patients in dialysis, there is one in-person visit that have to happen after the dialysis starts, and then they need to be followed up only remotely. But these 3 visits a year have to happen. For patients who receive a transplant, the schedule of the visits is the same as for patients before end-stage renal disease. So 1 annual in-person visits and 2 remote visits. This is very important because not being compliant with these visits would imply a loss of compliance, even if these patients are in end-stage renal disease.
Okay, so now that you have all heard how important retention is moving forward and what retention means for CureGN2, I'd like to take some time today to talk about what we can do to enhance retention. So as they mentioned, I'm Sam Sharp. I am the MWPNC CureGN monitor. So I have had the opportunity to speak to a lot of you via phone webinars when we've done your site's monitoring visits. We're less than halfway through everyone though, so if you haven't spoken to me yet, you will. And one of the things that I've asked all sites to do is to think about retention and start coming up with strategies on how to retain your patients because no one knows your subjects better than you do. And I don't believe necessarily that retention is a one-size-fits-all approach. I really think, like medicine, it's personalized to each individual subject that you encounter. So we're going to talk about some strategies that you can use today to help you as you think about your retention plans moving forward. And we're also going to ask you to do a breakout, and we're going to have you form groups of at least 4. And we want you to brainstorm within your group about ways that you have retained your patients. And if you have specific examples too, where an issue came up and you came up with this really awesome creative way to keep them in the study, please share those things today because what worked for you might work for someone else as well. All right, so this first slide is a little busy. This actually comes from a journal article, and study coordinators and some are not. And that's why this juncture in CureGN is so important, because you have the opportunity to have your voice heard. And so the parts of CureGN that make it really hard to retain your individual subjects, you need to use your voice and get those things out there so that if it's something that can be modified within the protocol, then you have the opportunity to do that. And then there are things, obviously, that we can do as coordinators on our own that can make retention happen. So I'm not going to go into this slide in too much detail, but this is in your handout, and it's kind of a good summary of a lot of things we're about to talk about. So the very first thing I think is important when you're trying to retain your patients is actually something as very simple as just clear, concise, effective, and frequent communication. And I think that actually starts with enrollment. So please keep this in mind as we move to Cure 2. As Dr. Gibson alluded to, when you enroll a patient, if you can be as clear as possible about what their study commitment is going to look like,
and build that relationship from day one, then they're more likely to stay with you as time goes on. So I would say that. And then I think the other thing is building strong interpersonal relationships with your subjects and their families. And so when I was working at Nationwide Children's as the study coordinator, I would begin each of my patient visits talking to them about what was going on with that child and what was going on with that family. And I would write myself notes within the chart. So if they ran track, I made sure that I noted that they were a track runner, so that the next time I called on the phone, even if I was just talking to mom, I would say, hey, how's track season going? Just so that the families know that you're not just interested in them as a study participant. They're just not a number to you. They're actually a family. And I think that can be very powerful. So I would recommend that everyone use that. It doesn't take a lot of time. You can do it very briefly at the beginning of your visit. And then I think the other thing, like I said, is understand what their individual barriers are to study participation. I had subjects that they didn't have a consistent cell phone. Their phone number would change all the time because of their income level. And so getting to know your patients and really clearly defining what's expected of them and figuring out a way as a team to kind of work around the things that are going to get in the way is really important. And then the other thing along those lines is then you determine what their communication preferences are and when is best to contact them. I would say collect as many phone numbers as possible. Sometimes I would joke on my bad days and say that my job was a professional voicemail leaver because I felt like that's all I did was call people on the phone and leave messages. Please be aware when you're making your phone calls that there are institutional limits regarding how many times that you can contact a patient. So at Nationwide Children's Hospital, we have 3 contact attempts. So usually we would call them twice by phone, and then we would send a letter as the kind of the last attempt to remind them that they've kind of disappeared on us. I also used our site's nephrology clinic and used their administrators as well. I would often send an email and say, you know, so-and-so is due for a research visit. They're also due for a clinic visit that's not scheduled yet. Can you help me get that scheduled? This is the window that I need to see them. Can we line those things up? So your nephrology clinic administration can be very helpful with you with that. And then I would say it's always important to let the patient know what's coming next. So I would always make sure, whether it was an in-person visit or by phone, when I would be contacting them again. And I would always do appointment reminders as well for in-person visits. So call them a week ahead of time, say, hey, remember you're coming in to see Dr. So-and-so for your nephrology visit. I'm going to be seeing you. We're going to get blood and urine, so that they just always have that expectation of what's coming next. I think it helps. People get busy. People don't answer the phone. So just do what you can. And I would say along with that, some sites are allowed to do email. That's an IRB dependent thing. Maybe with this single IRB coming in CureGN2 that we can get that put in there across the board. Because some people don't like to answer the phone, they don't like to talk, but they'll click on an email and they'll answer a couple questions. So if we could formalize remote CRFs that could go out by email, I think that could be something that could potentially help. And then some sites are allowed to use text reminders for visits, others aren't, but just options to explore as you're thinking about retention. And then I think I've said this throughout the presentation, but I think it's just important to set very clear expectations. What does participation in CureGN look like? And we all know it's difficult to get blood from pediatric patients. Sometimes it is so tough. It's really hard to draw on that 2-year-old that's sitting there with crocodile tears. It just is. But just reminding the family what the expectations are, and then obviously you're always going to err on what's the best for the subject in front of you. And then I think it's just a matter of documenting. Again, also explaining the visit schedule and the requirements for each visit type. And then, unfortunately, we can't offer our patients a lot in terms of direct benefit right now. I think things that are coming down the pipeline, like the CureGN participant dashboard, change that discussion a little bit. But I think it is important to try to disseminate those newsletters and let them know that their samples really are being used, and then they can feel like the train is moving for them. And then, but you don't want to make false promises, obviously. So just being very clear about what results will be returned to them,
and what those possible timelines might be. I know one of the things that are in a lot of the consent forms are return of genetic results. And the really exciting thing is that genetic testing is happening now. So maybe within the next 5 years, we might be returning genetic results to participants. Maybe not within 5 years. You know, we never know with these timelines, but that's a really powerful thing. But I mean, I wouldn't promise them that, but it's something that's, you know, possible for them. So I think it's important to just remind them why we need to follow them over time, you know, why we need their longitudinal data, why it's important to keep track of every medication they're on. And that goes along with this slide as well, just engaging them in just CureGN and kidney disease research in general, and just reinforcing how significant their participation is in answering all the questions that we hope CureGN will answer for kids and adults with glomerular disease. And I already said, you know, you want to make sure you just continue to reiterate how important it is to collect this data and this biosamples over time, because unfortunately the questions that we're asking can't be answered with a one-time blood draw. We wish it could, but it can't. And then as you're thinking about retention, especially as pediatric sites with subjects that may be transitioning to adult care, you know, start talking to them early about what that transfer might look like. And this last point on the slide, I actually think is really important. If your site PI is not the primary nephrologist treating this kiddo in front of you, I think it's really powerful if you're able to have your site PI just spend a few moments with them when they come in for their in-person visits. Even if it's just as simple as walking through the door, shaking the mom and dad's hand and saying thank you for your participation in CureGN, having them reiterate how important their participation is for the long-term goals of the study, and providing them information and answering their questions. I think that can be a very valuable thing. Along that, as you're thinking about recruiting to replace in Cure2, I would have the PI be involved in the consent process as well. I always found that my subjects that were most invested in the study were because of the message that came from the PI first. Because if they feel like their treating nephrologist and their PI really finds value in the study, then I think that increases the value they find in it as well. So be a team. All right, and then this slide just is a reminder as a coordinator, try to stay aware of the updates on how CureGN data is being used. We listed some resources here on the slide to kind of help you keep track of that. As I was listening to Deb's presentation earlier, I think there's an opportunity for maybe a committee to be formed that could help notify coordinators of some of these things. We all know you have a high burden between visits and processing and data entry, that maybe if that could be something for Cure2 is have and the single IRB would obviously interface with that. And so if we could have something that would go through that single IRB that would be approved, and we could start disseminating this information to our patients and have it already prepared for us, I think that that could be very beneficial. But for now, your resources include the curegn.org website, your PI at your site, coming to these PCC coordinator meetings and hearing about the things that are going on, discussing updates with the lead coordinators, face-to-face meeting notes, and then the patient newsletter as well. Okay, so these are just additional strategies for you. These are things that you can do at the site level. Again, a lot of these require approval through an IRB. Some people find it to keep that engagement and that frequent contact going, to send those milestone and those thank you cards, to send them cards on their birthday, to send them calls during the holiday, or something as easily as simple as keeping track of when their birthday is and just calling them and wishing them happy birthday or leaving them a message. Those are small things that you can do that just might help them feel more engaged and in touch with the study. And then, you know, some other things that obviously money is always a part of these discussions, but there's the ideas floating around about having CureGN labeled items that you could disperse to your patients. As far as CureGN site transfer goes, if anyone does have pediatric patients that are looking to age out of pediatric care into adult care, there is the adult side of CureGN, and so we can help you identify where that closest closest site could be. There's obviously other options. You can follow them at your site and just do research-only visits. So there's lots of things, but if you do have patients that are transitioning, your lead coordinators are always a great website or a great resource to help you through that process. And then this slide just tells you as well that you can go to the curegn.org website, and there is a map that shows all CureGN study sites. So this is just the take-home messages from this portion of the presentation. So I feel strongly that patients are more likely to complete a study when they have a close relationship with both their coordinator and their PI. And I think it's what works for one pediatric patient for retention and engagement isn't going to work for another. So a younger child may enjoy having a sticker chart that they get to put a sticker on their chart every single time they're brave and they give their blood. School-age child might like to be a research superhero. You know, you can have cheap capes or masks, and when they give that research drawl for the year, you know, they can be your research superhero of the day. Or you could even simply have like a little badge for them to wear. Teenagers like to be featured in newsletters, and then adult may enjoy more of a review of recent publications. So I think you really have to personalize your approach to your patients, and no one knows them best but you. And then again, just communication, be as flexible as you can to try to adjust to their needs while still maintaining the study protocol, and then set clear expectations. All right, so the things that now we want you to break out into those mini groups, and these are the two things that we'd like you to think about. What have been your biggest barriers to retention? And then what methods have worked for you in terms of retention, both for keeping your patients engaged and not losing them to follow-up, and for those pediatric kids that have transitioned to adult care. So we'll ask at this time, we'll have everyone break off at least into groups of 4. You'll have about 15-20 minutes to discuss these questions, and then we're going to actually ask one person from each group to come to the microphone and share some ideas that your group has generated. And as I mentioned earlier, if anyone has specific examples, please share those now.